So I would like to thank all of the panelists again for these talks. They were very interesting and very informative, and I think we'll have a pretty interesting discussion. We have some time for question and answers if there's anybody. We will not have the Q&A from the web for this time, so people in the room feel free to come up to the mics at your leisure.
Hi, Steve Modell, Health Management Policy. Thank you for three amazing talks that each dovetailed with each other. This is to Sean. Are there any particularly prominent protective or ameliorative factors that move an individual to that point that you called redemption, speedier? And if so, how would you rate attending to those factors versus simply catching somebody at a critical life transitional point?
So, I mean, I think we know some things, like people who complete programs successfully, drug rehab programs, employment programs, they have much better outcomes, 20% reductions in recidivism than those who don't, okay? The problem comes to whether it's causal. When we do experiments of causally assigning people to these, we often find no effect. And so then, and what you find, and the issue here is people that are more motivated or somehow more interested in change or something are more likely to participate in these programs. And so then the question is that information still interesting? And I personally think it is, because you're not using static risk factors to identify people as low risk. You've let them do something. You've given them an opportunity, probably not a harmful thing, to participate in a program. And you've allowed them to identify as themselves. In terms of, I think there is some evidence that drug treatment programs are effective. And I think that's, you probably know a lot more about that than I do. And I think a big part of the story that's going on in this conversation, especially post-1990, is in fact incarcerations for people involved in drugs. So, I think drug treatment is one of the things that people have found some, but it's not a panacea. It doesn't work for everybody. And, I think the psychologists would argue that cognitive behavioral, so in the corrections field, the one program that gets a lot of attention is cognitive behavioral therapy. And so, which is essentially related to this identity shift. You have to think about yourself differently. And so I think there's some reasonably compelling evidence that works. And so I think that's another area. I just think that it gets tricky because, in terms of causing these types of shifts is a tough business to be in.
And then, yes, so I see your cautions. And then how would you rate addressing those programs or enhancing their use versus simply catching a person at a critical decision point, what you brought up in the last quarter of your time?
Yeah, I'm not arguing that you shouldn't stop trying to affect change, but I do think that there is a point at which people can get pretty frustrated because program after program. You want to kill a program, evaluate it well, and you'll show it won't work. It's depressing. So you start to think that people can't change, and the reality is people do change, and I can show you that there's lots of evidence that people desist. The hard part is figuring out how to cause that. And so I'm not arguing that you should stop trying to cause it. I'm just saying that there's also probably some room here for catching people when they stop. And so I'm not arguing either or. In terms of programs that are effective, I think work programs are the thing that people most like to talk about because they're the most sort of socially, they're most sort of value neutral. But most work programs, just sort of general give a guy a job, don't seem to work, and so then they start to transform into more sort of normative, get involved with their lives, help them, support them. They turn into things that sound more like cognitive behavioral kinds of things. So I don't know if that, but I'm not arguing either or. I'm just saying in addition.
Okay, I think we'll take one from this side and then one from this side. Okay.
Hi, my name's Lauren. I'm a student here at SPH in Health Management and Policy. And I was just wondering, this is sort of for all of you, but maybe more for Dr. Binswanger. What do you see the role of public health departments in providing medical services in institutions and then sort of helping with the continuity of care and putting people back into the public health systems when they're released, versus the current trend to privatize systems which then don't have those already existing connections and sort of that falling off of care.
So I don't know how many systems in the prison systems have their health services provided by public health departments. I don't think that's a very common model. What I have seen is some jail systems in major cities that have the jail health services provided by the public health system. And without any evidence to support this, I like the model only because it creates a financial incentive for essentially an alignment between correctional health services and community health services, so that they're not fighting over the money. That's all essentially public money, but there's not a kind of a disagreement over that. And that they, sometimes in San Francisco, for example, they have been able to standardize.
I worked for the San Francisco
there,
Jail
okay,
Health
yeah.
Services, so
So they've been able to standardize services, so you know this well. They've been able to standardize services across the two systems, which is something I really like. I don't know as much about private health systems providing correctional care. That's an extremely common model for state departments of corrections. And then, of course, there's some instances where there's university systems providing health care as well. But I'd know less about how exactly that could work. But I don't think in general the current system is working that well. I haven't seen that many examples of good continuity of care between the systems. And even in systems where the public health department may provide some of the services in corrections, that doesn't mean that the medical records talk to each other. So it's still, there's a lot of barriers in terms of physicians even obtaining a list of up-to-date medications from the correctional health providers to be able to continue the medications. So there's some very basic barriers that are really a challenge in that. Like even in our system, our Denver Health, where I see patients, has the contract for correctional health services, but I still can't see the records from the inmates while they're in the jail. So they may come in and out of the jail, and they're my primary care patient, but unless I get a signed request release of information, I won't get those records in a timely way at all.
thank you.
Yes. All three of you gave very powerful presentations on both, the medical, the dynamic, the what's happening sexually inside the prisons. It seemed as if you did not necessarily, Dr. Khan, deal with the, homosexuality within the prison, or we can call it homosexuality or same-sex relationships within the prison. It seems more often than not in the black community, it is seen as the reason why the HIV population the HIV explosion occurs in the black community is that the males go in and have sex inside and with each other and then come back and affect the women. But you brought up an interesting point that it can also be other partnerships that are going on. You didn't deal with that so much inside the jail. Do you have any statistics on that? And then thirdly, as a clinical psychologist, you also brought up Dr. Bushway, the fact that, okay, sometimes we have big problems and put them on, and we have small programs that deal with big endemic problems. At what point does this information from the public health community become a rallying point for advocacy for change in how we transition prisoners out and how we look at, race in this context? So those are.
Dr. Khan, would you like to?
Yeah, thank you for that question. So there are studies, incidence studies, where people are recruited at baseline when they come into prison and they're negative, and then they're followed over time. And there is incidence. There certainly are people who seroconvert in prison, which would suggest that there is some in-prison transmission happening. But the levels are so low that it can't account for the differential that we're seeing in terms of people with a history of incarceration and the levels of HIV risk that we observe. So it's really, because the levels are so low, it's assumed that most of the transmission is occurring in the community where there are more opportunities for transmission. That being said, it is vitally important to try to understand in-prison potential for transmission, not just for HIV, but for other sexually transmitted infections. And so, but it's hard to ask those questions on in-prison surveys. A lot of facilities don't want those questions asked. They don't want it to become sort of brought to the light that that happens. So like in our study, for example, in doing a follow-up study, and I have to say the North Carolina Department of Correction has been phenomenal in terms as a partner to try to improve health, allows us to, and that's where the data collection is taking place for my particular study. But we ask about in-prison sex at the follow-up interviews when they're in the community, just so we're not sort of pushing those buttons. But I think that it's something that we have to understand better in order to provide services and condoms if needed in prisons. So it's a good point. Thanks.
And Dr. Bushme?
I guess since the question sort of focused on reentry, I think maybe one of the things I wanted to get across is that if you spend any time thinking about reentry at all, you end up thinking about how people got there in the first place. It's a bit of a Trojan horse, actually. It's quite clever. People didn't, in the late 1990s, people didn't want to talk about sentencing because we'd had a big conversation about sentencing for 20 years, and we decided how to solve it. We were going to punish people, and we were going to do it retribution, in a proportionate manner. And so, by focusing on reentry, we actually reopened the conversation, because the conversation about reentry is really about how you sent them there in the first place. Because, and so. I think that, so I would focus on, I think the real issue here is that we have, we talked about, Ernest talked about, Dr. Drucker talked about the $1 million blocks. Well, those $1 million blocks are also $1 million blocks in terms of mental health or healthcare costs. I mean, you can actually, they correlate very highly. And they're also public housing. So these are places we're spending a lot of government money. And yet, these aren't being coordinated at all. Because on one hand, we're trying to help you, and then we're going to punish you. Help you, punish you, help you, punish you. I think that gets a little confusing. And I also think it sort of works at cross purposes. And so I think we have to think about, it's very difficult if they're working at cross purposes. And I think at some point we have to come to maybe something closer to a harm reduction philosophy a little bit about this. And we also have to have an intelligent conversation about why we sentence people to prison. And I'm not sure retribution is the end all, and that it's currently perceived to be.
Yes, I was struck by the data on high school dropouts among prison inmates. It's very consistent with what I've heard before, and also, in terms of very high illiteracy rates. And there's been a lot of talk about the school-to-prison pipeline. I know we work in our Michigan Youth Violence Prevention Center in Flint, Michigan, which has a very high dropout rate. What opportunities are we missing, either on the prevention side, before people wind up in prison, or once they're there, in terms of trying to increase literacy rates? Are there things that you think we could be doing that we're not doing?
I think that the high school dropout issue is interesting. I think it's fairly compelling, actually. I am, unfortunately or fortunately, the guy who gets to be skeptical about the causal impact of these things. But I actually think one area, but I think there are places where the causal impacts are fairly strong or fairly clear. And one is if you get involved with the criminal justice system as a juvenile, it does causally lead to dropout. And the mechanism by which that happens is fairly obvious at some level. But I think it's been shown pretty clearly, maybe not without a shadow of a doubt, but I think it's pretty clear. But the thing about dropout that's always been really striking to me, and I had a student do this project, you can predict who's going to drop out of high school at 8th grade really, really well. Like R-squareds if you can, with about 60% accuracy in terms of R-squared. It's not accuracy, but you can explain it really well. And that's scary because that's 8th grade. And we know that dropout may not be causally correlated with lots of other things, but certainly correlated with lots of other bad outcomes. And so I think what I would suggest is that we need to be thinking very early on about what's going on in these schools, and particularly in schools where, dropout rates in some of these urban schools are so high, it's scary. So I think I'm not sure if I'm necessarily the right guy to give you the programmatic I sometimes have trouble in public health settings. I used to work with the CDC. They always wanted me to tell them what to do, and I had no idea. But I do think that's a place to focus. I think the schools are good environments. And one thing I worry about with schools is they become very much criminalized in urban areas in particular. There's cops everywhere. And that's a real trend that's happened in the last 15, 20 years that I'm not sure is a good idea. It certainly increases racial disparity because I can guarantee you the cops aren't in the white suburban schools because parents won't let them go into those schools. But I also think that it continues to set up these help hurt kind of problems that I think the government, we as a society need to decide what we're doing here. Because if you do get put into the criminal justice system, you're going to be. I mean, the juvenile justice system is not a punishment system. It is, in fact, a system that's trying to help. But that is its goal, right? We switch gears at 18. We say, okay, now we're not trying to help you anymore. We're just trying to punish you. But I think I think it's a target place that I think schools are an environment where public health maybe hasn't been as involved because that's education. But I think clearly over time, what I've seen is there is more involvement with the public health system in schools.
From this side?
Amanda Geller, Columbia School of Public Health. I actually have a question for Sean that kind of piggybacks on the last one. And one thing I found really striking about your talk is the ubiquitousness of the criminal justice system to the point that 30% of people under 23 are arrested at least once. But then you juxtapose that with a prison population that's so disadvantaged at the point that they come in that there is clearly a tremendous amount of selection between the first arrest and the question of who comes into prison. So I'm wondering, so part of that I imagine is personal selection, and part of that is probably policy and practices that are in place to deal with people who have been arrested and disparities in that. And I was wondering if there's anything, I know the arrest study deals with the NLSY data, anything else in addition to dropout that's been shown to be kind of risk or protective factors for kids who've been arrested that can kind of divert them from the trajectory towards prison?
I think that in terms of protective factors, I have a study that's just recently been published, which is part of the Rochester Youth Development Study, and we looked at protective factors, and we found that positive involvement in school and parents can even help 17, 16, 17-year-olds who are very high risk. So, which is not what people typically expect. By the time you're 16 and 17, if you're pretty heavily involved in crime or the criminal justice system, that's tough to change. But, we did find that parental involvement, parental supervision, and school involvement, relationships with teachers, that kind of thing can be helpful. It's just hard. I mean, anybody that's involved in school prevention programs, after-school programs, right? You run this wonderful after-school program, and who shows up? The kids who don't need it. Right, it's a very tough problem, but if you have the folks that are there and you can somehow reach them, there is some evidence that you can help them. One thing about the sorting mechanism, that's important to note, especially with respect to the racial disparity. I think the evidence is quite compelling that there is a lot of racial disparity with respect to incarceration. Just look at basically 8 times disproportionate. But you can basically explain that disproportionality with arrest with things like homicide and very serious crimes. For good or bad, African Americans are arrested for homicide, say, at a rate that's about 8 times. So they're also in prison at a rate that's 8 times. Where that is not true, where you can't explain is with drugs. Only about 40% of the variation in the racial disparity in drug incarcerations can be explained by arrest, and that's where a lot of discretion and things are going on. And that's, I think, an important lesson in terms of we do have discretion as to who ends up in the final system, and that discretion may be used in a racially biased way.
Chris Holdeman.
I'm super sorry for keeping everyone from lunch, so I just apologize in advance, and I will try to be quick. So, Sean, I have a couple of questions for you. I apologize. So I think, the 2 things that you said that really struck me, and I really enjoyed the presentation, is so the first is just, you talk about earnings, and there's clearly a floor effect there because they're at the left tail of the distribution that's bounded at 0. But I guess the thing that I'd like to hear you talk about a little bit more is to bring Maria and Ingrid's findings in here. For mortality rates and for number of sexual partnerships, you'd expect those guys to be at the right tail of the distribution. And for those sorts of outcomes, the floor effects don't apply. And so might we see some effects there, whereas we'd miss them with earnings? And then the second thing is just, so I don't love exogeneity as much as an economist, but I like it a lot for a sociologist. But I think, the thing that makes me anxious with some of those studies is, so Charles's study, which I like a lot, it's Illinois, so all those guys had already been in pretrial detention. And so the treatment that they're getting is either, depending on how you think about it, either a felony conviction contingent upon already having been incarcerated for a while relative to not, or more incarceration layered onto incarceration. And so I guess I struggle with that. And then on a practical level, the fact that if you're interested in families or these other sorts of things, it's just really hard to link people in administrative data. So I'd love to hear you talk about the practical concerns. Amanda has really good ideas about how to do that stuff, but those are my two things. I did enjoy it.
So what was the first one again? I was concentrating on the second one.
Sorry,
I should have
floor.
a pen and I don't.
Floor effect.
Okay, yes, okay. So absolutely, not everything has a floor effect, clearly. So that's, and death and sexual behavior are two things. The question I'd have for Maria is just that, if it's incarceration, but okay, compared to who, right? So probationers. And so, again, getting the controls down. But it's not, so floor effects aren't always the issue, right? But it is this question of controls. In terms of death, death is I've had some really great conversations with Ingrid, and she's been very responsive to some of my concerns. And I just want to say, by the way, I'm never coming to a public health conference again where I'm going to present with public health people. They're really good speakers. Is just that death is really hard because when people die, they go out of your sample. So, so it's hard to study pre-arrest. You can't compare pre-incarceration death behavior to post-incarceration death behavior because once you die, you're not there anymore. And so that makes this problem really tough to study. But it's a really important question to ask because I've seen, I've seen some interesting studies that just look at death rates of people that are about to go to prison, and especially African-American youth in Chicago, and their death rates are very high. Unfortunately, it's scary high. And their death rates in prison are actually quite low, and then it goes back up. And so you can see prison as protective in that context. But it's a very tough question to study. In terms of so Chris and I, actually, you might have guessed, we have a history. So we've talked about this issue before. And the exogeneity issue, for the point of, for this audience, maybe a way to say it is, the tighter you make the controls, the more precise you make the test, the more limited or less externally valid the results are. You get what econometricians call local average treatment effects. And so they're based on a certain source of identification. It's not that different than public health folks do with experiments, right? So you do an experiment, and then it's like, well, that's only relevant for this particular audience and this particular, and that same thing happens in this context. And so there is a bit of a trade-off. But I think the question for, in the Leffler study, that's group people in Chicago, some of them are assigned to judges who are harsh, some are not. And the question is, it's a question. It's not the only question, but the question is, if you get assigned to prison rather than probation, do you have worse outcomes? The answer is no, at least as far as we can tell precisely, given the precision in that study. Well, okay, it's true. A lot of those folks were incarcerated pre-trial. So my only point here is, so maybe it's not about the incarceration decision that's causing the problem. Maybe it's the involvement in the criminal justice beforehand. The single biggest predictor of the probability of incarceration is whether or not you were detained pre-trial. That's time served. That's not a conviction. And that's not an incarceration sentence. That's part of the processing through system. That's bail that you can't make. right? So, but that's not the conversation we're having. But maybe that's the conversation we should be having, right? And so that's my response to Chris is, yeah, you're right. So if you don't find it for that effect, then maybe that's somewhere else. But then we should be focusing on that and not on the judge's decisions to incarcerate someone, because apparently that isn't the thing that's leading to differences in outcomes.
Okay. I think we're right on time for lunch. I want to thank you all again. Thank the panelists once again for their wonderful presentations and you all for your wonderful questions.